Okay, so this is the newborn with a perinatal injury or congenital malfunction, chapter 14. Okay, okay, so again, you want to look at your key terms in regards to this. This is a pretty long chapter that we're going to be going over today. So I'll try to be as brief as possible. Okay, so birth defects. So birth defects are abnormalities, and any baby that does have a birth defect is going to be very, very, very apparent at birth. And so this is one reason why you are going to be doing your evaluations and your assessment as much as you have seen in the other two chapters, because again, you want to kind of see if there's any deviations from the norm. Um, and once you know that, you'll know how to basically go about and you know, and report it to the healthcare provider so they can begin to start treatments for these certain birth defects. So today we have, box 14.1. It really goes over the classifications of different birth defects that you will see. For example, malfunctions present at birth. You have structural defects. You're going to have metabolic defects, blood disorders, chromosomal abnormalities, and also perinatal injuries. And perinatal injuries can include infections, drugs, maternal disorders, the Rh factor disease, and anything that can be difficult, show difficulty in labor or premature birth. So we're going to look at these different classifications and learn about those, their treatments, some of their manifestations. Okay. Now here on this slide it says birth defects, abnormalities that are apparent at birth. That's what they are. And the abnormality may be, again, a structural function, metabolism, groups that I just showed you. And you'll see all of that again in box 14.1. And yes, it can result in a physical or mental disability and may shorten life or may be fatal. Okay, and again, these are your classifications of birth defects. Malformations are present at birth. When you see that, they will be present at birth. And the following sections that we're going to see, we're going to look at the congenital malfunctions, and this is what we're going to look at first. So one of them is the first one we're going to look at is the nervous system. So remember way in the beginning, we always talk about the nervous system, the mother taking certain vitamins and so forth, just to make sure that the baby doesn't have any type of neural defects and so forth. So now we're going to look at some of these defects that can happen in regards to that. So the first one we're going to look at is, the neural tube defects. So the neural tube defects are most often caused by the failure of the neural tube to actually close at either the cranial top or the caudal lower end of the spinal cord. And these defects often result in what we call the hydrocephalus, or the other one would be spina bifida. So let's look at hydrocephalus. So hydro itself, meaning water, or encephalo, meaning head. The newborn has a condition of like what we call increased intracranial cerebral fluid within the ventricles of the brain. So when you look at the anatomy and physiology of the brain, we have this structure in which the brain has to have some type of drainage, and if it doesn't, you will have that increased pressure within it, which can cause the head itself to increase in size if it's not flowing or pulling out that cerebral fluid that's flowing around with it. So Basically what happens, it results in an imbalance between the production and also absorption of the cerebrospinal fluid, or improper formation of the ventricle. So hydrocephalus can be either, it could be congenital, they could be born with it, or it could be acquired and happen all of a sudden. It is most commonly acquired by some type of tumor, or some type of infection, such as encephalitis or meningitis. And the symptoms are going to depend on the site where it's located and where it's obstructed at. And also it can depend on the age at which it actually develops. So hydrocephalus is classified as non-communicating, obstructive, or communicating. So those two, so you have the non-communicating hydrocephalus. And this is from the obstruction of the cerebral spinal fluid flow from the ventricles of the brain to the subarachnoid space. Then you have the communicating hydrocephalus, and that results when the cerebral spinal fluid is not obstructed in the ventricles, but it is inadequately reabsorbed within those subarachnoid spaces. And your book does show a picture of like what both of them would look like in regards to the communicated and also non-communicated, and you will see that in figure 14.1. So how is this manifestation? How does this manifest? That's one of the things sometimes, you know, as a nursing student, it's really kind of good to understand, like exactly what's the rationale, or how did everything begin to happen. So you're going to have the signs and symptoms, okay, of the hydrocephalus. And again, that's going to depend on the time, the onset, and also the severity of the imbalance. So again, you have that classic sign, which is going to show that whole increase of the head size, and you know, and hydrocephalus doesn't only just have to happen, you know, once the baby's born. It can actually happen in utero also. So if it does occur in utero, the head, you know, the enlarged head will necessitate for the patient to actually have a cesarean section. And at birth, the head continues to enlarge rapidly and the fontanelles begin to bulge. So, you know, what we call if you remember the shape of the head, the cranial sutures, they separate to accommodate the enlarging mass of the head, and the scalp becomes really, really shiny. So you're thinking of like almost like a balloon, sort of, when you're filling up the balloon, and the balloon is a regular size, but then all of a sudden, as you add in more pressure, and this pressure has no way of being released. So it can happen two ways. The ventricles will fill up, or either the subarachnoid space, they begin to fill up, and that balloon, you know, thinking of it as a brain that around the scalp, it just continues to get bigger and bigger and bigger. So as that gets bigger, it's going to bigger, it gets really, really thin. So imagine a head getting really, really big and the tissue around it becoming really thin. You're going to see this like clear, like effect, like you can actually see the veins within the child's head, and it becomes, the scalp is very, very shiny. So also, and like in some cases, your book shows you that the pupils of the eyes may appear to be looking downward, and the sclera may be seen above the pupils. And it's like, they call it like a setting of the sun sort of effect. And there's a picture in your book, and I'll tell you where to look at. I think it's figure 14 too. So a foreshortened occipital suggests pathology of the fourth ventricle, with the brainstem protruding from the cervical canal. Well, that's also within your book, and that is called the Arnold Chiari malformation. When you see that effect. So when the enlarged head involves a prominent occiput, The condition usually involves what we call an atresia of the foramen luxca and the foramen of Magadai, and that is known as the Dandy-Walker syndrome. So those two, so I would just really basically highlight Dandy-Walker syndrome and kind of just figure out like exactly what that is. So again, so you have the enlarged head, um, and um, and it's going to involve what we call the atresia of the foramen luxca and the foramen magadi. And so those two together, those two conditions are involved, it's going to know you have that condition called the Dandy-Walker syndrome. So therefore, the infant is very lethargic, very helpless. The body becomes thin, and the muscle tone of the extremities is very poor. You would hear like a cry. When they cry, it's like really, really high-pitched cry. They're very irritable. Vomiting and anorexia are also present, and then some convulsions can also occur. Okay. And it is figure 14.2. You have a baby who has a marked hydrocephalus. Okay. Now, how is this diagnosed? So, trans illumination. Okay. Let's see if it's here. Okay. Sorry, I'm not. Transillumination. So that's one of the ways it's diagnosed. And just to go back here on the slide, so those of you who like to take notes a lot. So you have the symptoms, and these are the symptoms of increased intracranial pressure here. And again, you will see all of this, again, with the vomiting, the poor feeding, the bulging fontanelles in the infant. And it's going to be characterized, again, by that increased pressure in the cerebral spinal fluid. It's going to cause a lot of changes in pressure within the brain and increased size in the head. And it's most commonly acquired by some type of obstruction. Again, it could be acquired again with even like a trauma or something that can happen to the mom. It can be acquired. Symptoms depend on the site of obstruction and also age at which it actually develops. And again, it's classified as non-communicating and also communicating. And how is it diagnosed? So the diagnosed transillumination is one of them. This is the inspection of the cavity or an organ by passing a light through the wall. So when you see that, it's so clear and it's so thin, you can see through it. That's one of the diagnostic procedures useful in actually visualizing fluid. You also have echo the echoencephalography, oh my God, echoencephalography. They have that, and also CT scan, and also MRI, and ventricular tap or puncture. The echoencephalography and the CT scan and the MRI, those are going to be used to visualize any type of enlarged ventricles, and also it's going to help identify the area of obstruction. And the ventricular tap or puncture may be performed using basically a sterile technique, and this is going to determine the pressure and to drain any of this cerebral spinal fluid or CSF. Okay. And the way this is treated, so they do have medications to reduce the production of CSF or cerebral spinal fluid. And also they do have surgeries to actually you can place a shunt. And some of the medications you probably would be familiar with is the furosemide or the Lasix. And basically what it's going to do is going to reduce the production of the central cerebral spinal fluid, and also it's going to provide a lot of relief. But the surgery, if the physician does attempt to do a surgery, such as a bypass or a shunt, the cerebral spinal fluid, to drain some of that, The cerebral spinal fluid can be carried to another area of the body, and where it's going to be absorbed and then finally excreted that way. And this is accomplished by inserting like a special tube, and that's going to be placed, at intervals as the child begins to grow. So that procedure is known as a ventriculoperitoneal shunt. So this is this picture here in your book, and it shows you, the whole procedure, what that is. And again, it's not like they're draining that on the outside. They're actually letting it drain within to the peritoneal cavity, and then eventually it just drains out throughout the body and drains out itself. Okay. And we did go over some of those manifestations. Again, it depends on the time of onset and severity of imbalance. And again, your classic signs would be increase in the size of the head, cranial sutures separate to accommodate enlarging mass. Also, the scalp is shiny and veins are dilated. And this is the the ventriculoperitoneal shunt. Again, this is one of the treatments that they use to help reduce the CSF. And I did tell you that you can find that in your book. It's a great picture of it, figure 14, 3. The post-op care, so what do we do now? As nurses, of course, you're gonna prepare as a pre-op. So, most often surgical correction can be accomplished in utero via a fetal surgery or shortly after birth to prevent any type of brain damage by increased intracranial pressure, or ICP is another name for it. The immediate preoperative care is routine. And this is going to basically, you're going to be looking at the vital signs and skin preparation and emotional support, for the parents. And if the baby doesn't have corrective surgery, the nursing care for a child who has hydrocephalus and doesn't, undergo, they're going to have it's a lot of different things. They're going to be challenged, especially as they begin to grow. It's going to be hard for the baby to raise their head. A mental development it's going to delay their mental development. You'll see lack of appetite, tendency to vomit easily, and also poor resistance to infection complicated. If they get an infection, it can complicate, be more complication to the fetus. The position, when you're looking at the positioning, the position of the infant must be changed frequently to prevent any type of hypostatic pneumonia and also pressure sores, because again, it's hard for them to move their head, it's hard for them to position themselves, so you'll see that. And so therefore you want to turn, during that time, as a nurse, you're going to turn when you're turning the infant who does have the hydrocephalus, the head must always be supported, because again, it's putting a lot of strain on their neck. So you want to make sure that you turn the infant in bed and the weight of the head is basically in the palm of one hand, and the head and the body are rotated together, because again, you want to prevent the strain on the patient's neck. So when the baby is lifted from the crib, the head must also be supported by the nurse's arm and also the chest. So certain things you have to make sure when you're taking care of a child who does have hydrocephalus, this is basically prior to them actually having the surgery. So other things you're going to be doing preoperatively, you're going to be observing and recording and reporting. That's going to mean the amounts of food intake, any type of vomiting, the condition of the skin, any type of motor abilities, restlessness, irritability, and changes in vital signs. And also the fontanelles are expected for the signs and size of bulging, and head circumference is going to be measured around the the occipital frontal area, and that's going to be part of your documentation and recording also. And you're also going to be looking at the symptoms of increased pressure within the head. So basically, symptoms of increased pressure within the head are increased in blood pressure, and also decrease in, you'll see a decrease in pulse rate. So increase in blood pressure, decrease in pulse rate, and also decrease and respiration. That will show that the patient is having some type of intracranial pressure at that time. Also, signs of cold and other infections are immediately reported, and that's also going to be documented too. So during the time of post-op, um, you know, so in addition to your routine post-op care and the way you observe anyone after they come from surgery, you're also going to be observing for signs of intracranial pressure, again, the ICP, and also you're going to be observing again for infection at the operative site, and where the shunt is, the line of the shunt is going to be. And also there's going to be managing pain control for the infant, and remember to use those the pain chart, because especially if the baby's not able to tell you they're in pain, so you want to use one of those pain assessment charts just to make sure that you're assessing for pain and giving pain medication that's needed. And as in regards to infection, bacterial infection is very life-threatening at this time. And if it is, sometimes the shunt may have to be removed. So you're going to be looking for signs of infection. That's going to include taking the patient's vital sign, observing their feeding, checking for vomiting, looking at the pupil, the dilation of the pupil, any type of levels of consciousness. So you want to look at that. And also you're looking at for any signs and symptoms or just a seizure itself. And because it's an operative site, again, you're looking for signs and symptoms of infection, which is going to include inflammation. Okay, positioning of the infant is going to depend on several factors. And if the fontanelle is sunken in, the infant is going to be kept flat, because you don't want it to go too quickly, to sink in too quickly, and because this can lead to a lot of pressure in that area, and that can lead to seizures, or either some type of cortical bleeding. If the fontanelles are bulging, you want the infant is usually placed in Fowler's position, semi-Fowler's position, because you want to promote drainage. So it's going to be the opposite. So you want to promote drainage, and from the ventricles through the shunt. Okay, so that's very important. And so make sure you look at that in regards to positioning right after the post-op, because your main observation is going to be really looking at the fontanelles, whether it's sunken, what position to place the fetus in, the baby in, and whether it's bulging, what position to place the child in. You're also going to be looking, so you're also going to be looking at the skin, the assessment of the skin. That's going to be another priority. The head and the chest measurements, again, that's going to be recorded. And also the peritoneal shunts that are placed. The abdomen is going to also be measured, because you want to see whether or not if there's going to be any distension, or if the body is actually absorbing, the fluid. And one of the main things you're going to be looking at, signs and symptoms of increased intracranial pressure. Remember the high-pitched cry, the unequal pupil of the eyes in response to light, the bulging of the fontanelles, irritability, poor feeding. So you want to make sure you know what to look for in regards to intracranial pressure and the signs and symptoms for intracranial pressure. Okay, so all of those you're going to be looking at. And again, patient education, educating the parents, guiding the parents, teaching them the signs and how to look for infections and so forth, and signs of intracranial pressure. And other signs of, if it's an older child, um, signs of tube malfunction in an older child. Because sometimes you remember they put the tube in when they're younger, but as they continue to grow, they change the tube, depending on the child's age and the growth. So in an older child, they present with a headache, lethargy, changes in level of consciousness. You want to make sure that the family knows to report that. Okay. Okay, and here we go right here. Okay, about parent education and teaching of the signs to indicate shunt malfunction and so forth. Okay. Now, spina bifida. Okay, so this is another one. So we saw hydrocephalus. Now let's look at spina bifida. This is another neurological problem that that can happen to an infant. So spina bifida, another name for it is called the myelodysplasia, and it refers to a group of central nervous system disorders characterized by malformation of the spinal cord. So now we're looking at more of the end of the spinal cord. Before we were looking at more of the top part of the spinal cord, which has led to the hydrocephalus with there's too much pressure there, and the ventricles of the brain were not flushing out enough of that cerebral spinal fluid, or it was ending up more in those subarachnoid spaces. Now we're looking at more of another different type of neural defect. So the spina bifida, again, it can also be AKA it's basically a divided spine, and this is a congenital embryonic neural tube defect in which there is an imperfect closure of the spinal vertebrae. So there are two forms. You have the occulta, which is occult, which means hidden, and then you have the other one, which is more of a sac or a cystica, or a cyst. In your book, it gives you wonderful pictures of each type, and when you look at the pathophysiology of it, so the spinal bifida, occulta, the one that's hidden, that's picture A. So you have A, B, and C, figure 14 or 4, and you have the A. That's the spinal bifida occulta. Then you have B, is spina bifida cystica. What you see is more like a sac or a cyst. And then you have C, which is spina bifida cystica, which is more in the meninges, so it's meningeal myelocell. And so you see the difference between the two. But B and C, the meninges protrude out, and also the spinal cord protrudes out in C. So C, you have both of them, and with the protrusion of the spinal cord and also the meninges. Okay, so spina bifida occulta, which is the one that's hidden, and they have a great picture for that one too. In figure 14.5, the child has like a hairy patch by the lumbosacral region, which indicates that the spinal bifida occulta. So that's the difference, because it's not bulging out, it's more in, but it is characterized by like a hairy patch within that area. So the spina bifida occulta is relatively a minor variation of the disorder, in which the opening is small and there was no associated protrusions or structures, and it can often go undetected and occurs most commonly at the L5 and also the S1 levels. And again, there may be like a tuft of hair or a dimple or some type of lipoma or discoloration at that site. And that's the way you would know that's the occulta one, because it's definitely not bulging out. Treatment is usually not necessary unless it's some type of neuromuscular symptoms, And usually those symptoms consist of more like a progressive disturbance in the way the child walks, aka gait, or a foot drop, or a disturbance, or some type of disturbance of the bowel and bladder sphincter function. With the spina bifida itself, again, that's a little bit more. It's bulged out, and this consists of the development of the cystic mass in the middle of the spinal cord. Um, and again, you have the ones that you have the two types of the spina bifida cystica. You have the one with the meningeal myocele, and also the meningeal um, meningeal myelocele, so that one. Sorry, I was pronounce it. Let me find it here for you. It looks like it's not there either. So it's in your book. So you have the two kinds. You have the meningeal cell and the meningeal myelocele. So you have those two types of the spina bifida. One of them has the actual spinal cord, and the meninges actually protruding out. So the more serious is the meningeal myelocele, because you have both. And you have the membranes of the meninges, and you also have the spinal cord, and it's actually going through the opening. Again, from your book, it says, although it resembles the meningeal myelocele, there may be an associated paralysis of the legs and poor control of the bowels, and also the bladder function. Hydrocephalus is common, is a common complication, and also prenatal detection is possible through ultrasonography and testing for increased, alpha fetoprotein in the amniotic fluid of the mother. So usually with the meningeal myelocele, again, you may have hydrocephalus, could be common, along with this, with the spina bifida. So there are some preventions, and we always talked about that earlier, and that's part of your nursing tip. So the intake of daily multivitamin containing the folic acid before conception can help reduce the risk of any type of neural tube defects, such as the spina bifida. Okay, so that's one of your things that you could do there. And so treatment for spina bifida basically is a surgical closure. Habilitation is necessary after the operation because the legs remain paralyzed and the patient is continent, and also have, the patient is incontinent of urine and feces. And they call it habilitation rather than rehabilitation to describe the treatment, because the patient is disabled from birth and therefore is learning rather than relearning. So this is why it's called habilitation. And as part of the nursing care, so, you're going to do your routine nursing. You're going to do your routine observations, and again, you're going to be, so with this one, your nursing care would be, you're going to be looking at the size of the sac, and the back is checked, and the area is checked for any type of tears or leakage. This is at post-surgery. The extremities are observed for deformities and also movement, and there may be some type of paralysis of the limbs. Also, you're going to be checking for the head circumference needs to be measured to determine the possibility of hydrocephalus being associated with spina bifida. The fontanelles are going to be observed to get basically a baseline. And the lack of any type of anal sphincter control, that might show that the patient is incontinent of both bowel and bladder, that's going to be observed and also documented. Okay. And just keep in mind that the higher the defect of the spine, the greater the neurologic defect. And make sure also in your book, it's going to talk about the positioning, which is really important. and because the goal is to prevent any type of pressure on the sac and to avoid any type of postural deformities. So when you're positioning infants with, multiple deformities, the nurse must try to guard against aggravating whatever that existing problem may be. For example, when we talked about the positioning of the child with hydrocephalus, so the same thing, positioning a child with spina bifida. With the spina bifida, the infant is usually placed prone with a pad between the legs to maintain abduction and to counteract, hip. Okay, hold on. Just lost my notes just now. Okay, here we go. Okay, here we go. So the infant is placed prone position with a pad between the legs to maintain any type of abduction and also to counteract hip subluxation. So, um, you know, so again, prone is going to be on the stomach, so because you want to make sure that the area, where the surgical site is basically is going to heal. Also, a small roll is placed under the ankles because you want to maintain foot position. And some infants may be supported in a sideline posture to provide all that extra relief. Your book states the disadvantage of that type of position is that it reduces any type of movements of the arms and it also flexes the hips. So therefore, this is when the physical therapy staff may provide, more helpful consultation and, um, during that time, okay? So again, you wanna read up, it's a lot within that section. So you wanna read up more in regards to what to do post-op and also what to do, you know, in regards to if there's, a shunt and so forth in place. So again, with the post-op nursing care, that's going to involve that neurological assessment and also preventing infection. Okay. And then special consideration must be given to the establishment of the parent and also infant relationship because, the parent now has to learn the parent was probably really overwhelmed. So they, just basically a lot of education and teaching to the parents. Okay, so that's the neurological system. So you have the hydrocephalus, you have the spina bifida. So now we're going to look at the GI, and we have what is called cleft lip. So we're going to be looking at cleft lip, and then we're going to look at cleft palate. So the cleft lip is basically characterized by a fissure or opening in the upper lip. And basically, like what it says here, is failure of the maxillary and also the median nasal processes to unite during embryonic development. In many cases, it is hereditary, and sometimes others can be environmental, and it appears to occur more often in boys than in girls. So there is a picture here, figure 14.7. You do have the infant with a unilateral cleft lip and also palate. And palate would be like the top part of the upper part of the mouth. The treatment and nursing care. So the initial treatment for cleft lip is a repair known what we call a shallow plasty. And the cleft lip is repaired before the age of 6 months when weight gain can be established and the infant is free of infection. And then, of course, you're going to have the post-op care that you will have to do as a nurse. So for post-op, your main goal, is for the infant undergoing this cheiloplasty, is you want to prevent the infant from sucking and crying, which could cause tension on the suture line. Careful positioning of the infant, never on the abdomen, to prevent injury to the operative site. Also, you want to prevent any type of infection and scarring by gently cleansing the suture line to prevent crusts from forming, preventing injury to the perioperative site by using a elbow restraint, and something they call a Logan bow. And this can be applied for a short time postoperatively. Also, you want to provide for the infant's emotional needs by cuddling and other forms of affection. And you also want to provide the pain medication for pain relief. But one of the important pieces of it, and then we'll, just briefly, let me go into cleft palate before we go into that one. Um, so So the cleft palate is the failure of the hard palates to fuse at the midline during the 7 to 12 weeks of gestation, and this forms a passageway between the nasopharynx and also the nose, and also increased risk of infections of the respiratory tract and also middle ears. So the cleft palate treatment, the goals again, that would be the union of the cleft, improving feeding, improving speech, improve dental development, and nurturing of a positive self-image. So post-op. So post-op is going, again, for both of them, it is preventing infant from sucking and crying, the careful positioning to avoid injury to the operative site. But those are some of your post-operative nursing care. But the main thing is, nutrition, the feeding, the oral hygiene, and the speech. So the nutrition, again, that's going to be progressively advanced. No food through straws to prevent sucking. Oral hygiene. Follow each feeding with clear water to cleanse the mouth. And also speech. Encourage children to pronounce words correctly. And it talks about that in your book. When it comes to the feeding, the infant is going to receive feedings by a dropper until the wound is completely healed within the first 1 to 2 weeks. Um, and the infant is usually fed breast milk or formula as soon as the clear liquids are tolerated postoperatively. So basically, care should be taken to avoid touching the suture line, number one, especially when you're inserting that medicine dropper. Um, sucking is prevented as much as possible, again, until the suture lines are healed. So therefore, placing a small amount of breast milk or formula into the infant's mouth allows time for swallowing, and also it allows to not for the baby to not aspirate. So you're going to offer small amounts of sterile water, to cleanse the mouth after feeding, because again, you want to clear the area, prevent aspiration, make sure everything's clean, decrease, infection risk. Um, formula or drainage is drainage is gently cleaned from the suture line. You want to use saline solution for that. Um, an ointment, if the doctor prescribes it, that can be used, that can be applied to the skin. Um, and also, you want to hold the infant during feeding, and also burping. You want to burp them frequently. And then you want to place the infant in an infant seat after feeding, or on or on the right side, propped with some type of rolled blanket, because you want to, you know, um, this is make sure that any drainage or anything that the baby's bringing up, and also to prevent any type of aspiration. So this is patient teaching, things you're going to be teaching the mom, and you're going to be assisting her throughout this time so she can learn how to do this at the time of discharge from the hospital. The baby is discharged from the hospital. And again, as a safety alert, suction in the mouth should be avoided in infants who have a cleft palate repair. Okay. When it comes to other postoperative treatment and nursing care in regards to cleft palate, diversion. So diversion is to be prevented as much as possible. Play should be quiet, particularly in the immediate post-op period, and the nurse reads, draws, or colors with the child. Any other complications that you will see in regards to the cleft palate after surgery? You will see ear infections, and dental decay may accompany cleft palate. And parents are instructed to take the child to the healthcare provider at the first sign of an earache. And this is part of the information that you will be giving the parents. So now let's look at musculoskeletal system. So within the musculoskeletal system, you have what we call clubfoot and pathophysiology. So that's going to be one of the most common. That's one of the most common deformities. Okay, that's one of the most common deformities of the skeletal system, and this is characterized by a foot that has been twisted inward or outward. And the incident is about 1 in 1,000 births. Your book does show a picture here of what a clubfoot, you know, looks like. So again, you have a lot of malforms that are caused by improper position in utero, and and a lot of times what the doctors do, they can go in and do like manipulative exercises to kind of try to clear those up. But if it does not respond to like simple exercise, they have certain, um, what other ways that they can kind to actually correct this. And the Talip's equinovirus is the most common type that you will see in clubfoot. You'll see the feet turn inward. The child walks on the toes and outer borders of the feet. And this generally involves both of their feet. Okay. The treatment, nursing care. So the treatment of clubfoot, that's going to be started very early, like it says here on the slide. And the muscles will continue to develop abnormally. They do have the conservative treatment, and that's going to be the splinting and also the casting, because they want to hold the foot in the right position. And they do this during the time when the child is really small. Even the passive stretching and the exercise, that can also be recommended, like I said earlier. If the cast is there, and they do place a cast there, again, in your book, it talks about cast care. So you want to make sure you review that in regards to how to care for the cast. And again, there's also going to be that emotional support. And as a nursing tip, in long-term care of orthopedic patients, educating the patients about any type of orthopedic devices, such as cast care, exercise hygiene, and treatment goals, is very necessary. As a nurse, you're going to explain the importance of frequent clinic visits and giving them the resources of the physician and any other resources that they need to be directed to. Okay. So developmental hip dysplasia. So developmental hip dysplasia, that's also known as a congenital hip dysplasia. And so, it's a term that's applied to various degrees of deformities. Like, for example, your book says subluxation or dislocation, or either partial, and it could be partial, and it can also be complete. And this is manifested by, basically, you have the dislocation of the hip is commonly discovered during a very basic visit to the doctor. And so, and that's going to be, so what the doctor usually do is, you know, the the infant is placed on your back, and the hips are actually flexed. So the infant is placed on the back with the knees and the hips are flexed. So the physician can press up against the thighs, of the normal hip, and you've probably seen this, they do this, if those of you who have babies, and they go to the doctor's office, and the doctor has the baby laying on their back, and they bend the knees and take it, and they actually push it back. So what they can see is the difference would be like a whole bunch of folding tissue, opposed to the other leg having like no folding tissue, and that kind of shows the characteristic and give the diagnosis right there. Um, and um, and and so, like here, what it says here, the head of the femur is partly or completely displaced, and you do notice this is more common in girls, and it's more apparent as an infant or toddler begins to walk. You'll see the difference with it. And figure 14.9 does show it. Early signs of dislocation of the right hip. So this one, picture A shows limitation of abduction. Picture B shows the symmetry of the skin folds. And picture C shows the shortening of the actual femur itself. Okay, so usually when the baby is in a prone position, one buttock appears higher than the other. So that's another characteristic that you'll actually see. And the diagnosis for the hip dysplasia, one, they will do what we call the Barlow's test, what I just said about the adduction and extension of the hips. Then also the Ortolani sign or click sign, and healthcare provider can actually feel and hear the femoral head slip back into the acetabellum under gentle pressure. And the treatments would be, so the Pavlik harness, they give a wonderful picture of it, the baby here, because so figure 14.10. So the Pavlik harness is used with infants age 1 to 6 months of age, and this is to maintain the hips in the position of the flexion and also the abduction position to try to really get them positioned back, into the hip. So with the treatment, it's going to be again immediately on detection of that dislocation, and the hips are going to be maintained because you want that constant flexion and you want that constant abduction for at least 4 to 8 weeks to keep the head of the femur within the hip socket. Okay. So now let's look at metabolic defects. Okay, and this is going back again, the nursing care, for the hip dysplasia. So you're going to be observing, especially during the time of birth to detect any signs of hip dysplasia. So you can always see it when the baby is in a prone position, the nurse observes the buttocks for any type of variation in size, and the legs of the infant should be equal in length, and the infant should be kicking both legs, not just one. So you have those nursing care, which you will see while the baby is in the nursery. Also, they have what we call the spica cast. That's another what they actually can place the baby in, if not the Pavlik harness. So the spica cast encircles the waist and extends to the ankles and the toes. So you always want to make sure that you're doing a neurovascular assessment because the baby is in a cast. And there is a great nursing care plan here in regards to the infant or child in a spica cast. You have some nursing care plans for that. And also your skill technique for turning the child in a body cast. Okay, so let's look at some of these metabolic defects. So PKU, we talked about that before. The classic phenylketonuria, and this is a genetic disorder, and it's caused by the faulty metabolism of the phenolin and the amino acids that's essential to life, and it's found in all your, your protein foods. Okay. So this is I'm not going to go too much into it, but so they do this. We talked about this earlier, some other chapters when we were discussing certain blood work has to be sent. It's mandated by the state, um, for blood work to be done. And we said we take it from the sole of the baby's feet. So with the phenylketonuria, um, the classic, what it does is it's going to result in severe retardation. And this is going to be evidenced during the time the child is during infancy. So that's why we always want to make sure that this is done in the nursery, because early detection and treatment is, again, it's mandated by the state. So, um, you know, they do it early because it can happen so quickly. Once it hits the urine and the urine test does come back positive, brain damage has already occurred. So this is why they do everything at the hospital and the nursery, getting those results and getting them out. So treatment can begin immediately. What happens, the infant appears normal at birth, but begins to show slow delayed development at least between 4 to 6 months of age. The child may show evidence of failure to thrive, have eczema and other skin conditions during that time. And they do diagnose it by doing a test called the Guthrie blood test. And this actually helps to detect PKU. And treatment and nursing care for PKU is going to consist of a close dietary management and also frequent evaluation of the PKU blood levels. Because because this phenolin is found in natural protein foods, and you know, um, so sorry, let me go, let me reiterate. So because phenolin, the PKU, the phenolin itself is found in natural protein foods, which is a food that provides enough protein for growth and tissue repair, but little phenolin must be substituted. So the most commonly used formulas that you would use, see the babies using, are, and make sure you highlight this in your book, is the lofenolac or the Phoenix one for infants. You also have the phenol-free for children, and also the Phoenix for adolescents. So basically, the goals are going to be for the diet is to provide enough essential proteins to support the growth and development, while maintaining phenolin blood levels between 2 and also 10 milligrams per DL. If any phenolin level that's going to be below 2 may result in growth retardation, and also levels above 10 can result in any type of significant brain damage. Okay, so make sure you highlight that and keep that. So as a safety alert, children with PKU must avoid the sweetener, which is called aspartame, or the NutraSweet or Equal, because it can't be converted to PKU or phenolin in the body. Okay. So the maple syrup urine disease is caused by a defect in the metabolism of a branch chain amino acid, and is caused by a marked serum elevations of the leucines, the isoleucines, and also the valine. So this results in acidosis, cerebral degeneration, and also death within 2 weeks if it's left untreated. And this is manifested, so the infant with the maple syrup urine disease, they do appear healthy at birth, but then later on you start to notice feeding difficulties, loss of moral reflex, hypotonia, and also irregular respirations and convulsions. And the child's urine is a sweet, like like almost like an earwax, like really honey looking, characteristic, and also a maple syrup odor. So this is caused by the ketoacidosis, and it's and you know, and this is what the ketoacidosis that you would see in diabetic children. Um, so the treatment and the nursing care. Um, so basically, again, removing the amino acids in your metabolites from the body tissue, hydration, and also peritoneal dialysis can take place to help decrease these serum levels. Lifelong diet low in amino acids that contain the leucines or the isoleucines and the valine. And also exacerbations are usually related, excuse me, to degree of abnormality of these leucine levels. And also when we talk about infection, you know, it can be life-threatening. So, you know, so therefore the nurse must frequently assess the patient and instruct patients about the need to actually prevent any type of infection. Okay? So the next one is the galactosemia. And galactosemia in the body is unstable, is unable to use the carbohydrates, galactose and the lactose. The symptoms of galactosemia began abruptly or worsen gradually, and you'll start to see signs of lethargy, vomiting, and hyponatremia. As far as for the nursing care, milk and lactose containing products are going to be eliminated from the diet with patients who do have galactosemia. Okay, so now let's look at chromosomal abnormalities, and that's going to fall under your under the Down syndrome. And so Down syndrome, so the pathophysiology. So Down syndrome is one of the most common chromosomal abnormalities. Its incidence is appropriately in like 1 in 700 live births within the United States. And screening, so basically they do screening. So the screening for the Down syndrome is offered during the first trimester of pregnancy. And this is going to include like ultrasound assessment of the thickness of the fetal nuchal folds, and also absence of the nasal bone. So when they do that early screening, it allows the parent to discuss any type of options of terminating the pregnancy or continuing with preparation for the outcome. So going back to look at it, you know, there are 3 phenotypes or genetic makeups of Down syndrome. So you have trisomy 21, the muscle chasm, and also the translocation of chromosome. But the most common type is the trisomy 21 syndrome, and that accounts for at least 95% of the patients. So Down syndrome can be diagnosed by a clinical manifestation, you know, but a chromosomal analysis will definitely confirm the specific type. So signs, so you have the signs of, you know, you have the signs of Down syndrome, which are apparent at birth, and you'll see the child that has the closed set and upward slanting eyes, a small head, a round face, flat nose, protruding tongue, and with the protruding tongue, it interferes with the sucking, and also you'll see mouth breathing. And also there is a deep straight line across the palm, which is called the simian crease. And the hands of the infant are short and thick, and the little fingers are curved. In your book, it does show you picture 1412, A, B, and C, in regards to the eyes, the feet, and also the finger, the fifth finger. So basically, the fifth finger does not extend to the distal point of the adjoining finger. Okay. So when you're looking at the developmental milestones of children with Down syndrome and also normal children, It does show you that in table 14.1 in regards to the sitting, the rolling, and crawling. So, for example, children with Down syndrome, you know, age 2, at age 2, um, you'll see them sitting. In a normal child, it'll be more like, at age 1, they should be sitting. So it's a little bit different. Crawling, the average would be, not age 2, sorry. Age 2, sorry. So they come and show, so they have the different milestones of when they should be sitting, rolling, or sitting alone, and so forth. Okay. Um, And they also show the same occurrence with self-help skills in the normal children and also those with Down syndrome. And of course, you're going to have you know, um, some nursing care in regards to counseling the patient and also the counseling of the siblings. Okay, and there was something else about Down syndrome. Um, Okay, so in regards to children with Down syndrome, the lifespan has increased, and because of the widespread use of antibiotics. Also, in your book, just reading from there, the limp, flaccid posture of the infant is caused by what they call hypotonicity of the muscles, and it makes positioning and holding more difficult and contributes to heat loss from the exposed surface area. So the infant should be warmly wrapped, basically to prevent any type of chilling. Also, hypotonicity of the muscle also causes respiratory problems, and also excess mucus accumulation. Um, any type of bulb suctioning may be necessary before feeding. And also, in addition, the hypotonicity of muscles contributes to the development of constipation, which can be controlled with dietary intervention. Let's look at peritoneal injuries. So just quickly, so you have the hemolytic disease of newborns, the Rh factor. We talked about that so many times. So the erythroblastosis fetalis. So erythroblastosis fetalis, and that was the one I was trying to remember earlier. Um, that's a disorder that becomes apparent during fetal life or soon after birth. And it's also one of the many congenital hemolytic diseases found in newborns. And it is caused when the Rh negative mother and the Rh positive father produce a Rh positive fetus. So we went through that before. So we learned all about that. So that's our whole erythroblastosis fetalis. So again, you really want to read this section again if those of you who have not gotten the mix of it. So now, again, it's about the mixture of the blood. So although fetal blood and maternal blood do not mix during pregnancy, small leaks may allow fetal blood to enter into the maternal circulation and sensitize the mother. So therefore, the mother's going to respond by producing other antibodies that's going to cross that placenta and destroy the blood cells of the fetus. So when that happens, it's going to cause, it can cause anemia and also possible heart failure. So if large numbers of antibodies are present, the fetus may become severely anemic. In the gravest form, according to your book, the progressive hemolysis cause anemia, fetal hypoxia, um, um, generalized edema, which is anasarca, and also heart failure, and that's called hydrops fetalis. And so, again, so those are things that part in your book you want to make sure you highlight and understand that in regards to erythroblastosis fetalis. And in box 14.2, terms helpful to understand the Rh sensitization. So you have the different Rh factors that we talked about. So this one, the first one talks about the antigen against, which is a substance that induces the formation of antibodies. So the antigen antibody reaction is the basis of immunity. But then when we look at the erythroblastosis fetalis, the Coombs test indirectly measures Rh positive antibodies in the mother's blood, directly measures antibody coded Rh positive red blood cells in the infant's blood. So that's what the Coombs test does. With the erythroblastosis fetalis, the severe form of this disease produces anemia in the fetus as a result of the incompatibility between the red blood cells of the mother and those of the fetus. Then you have the RhoGAM, which is an immunoglobulin given to the Rh negative mother after delivery of the Rh positive fetus to prevent maternal Rh immune response. And remember again, highlight that one too in regards to the RhoGAM, when it should be given. Remember, there's a whole bunch of certain times when you have to give that RhoGAM to the mom. Even when she's pregnant, it's a certain time you have to give that RhoGAM to the mom. So remember to highlight those dates. And then you have sensitization. Is the phenomenon in which Rh negative mother develops antibodies against the Rh positive fetus. So those are your different terms. And also box 14.3 talks about the ABO incompatibility in regards to, it says, the hemolytic disease with symptoms similar to those of erythroblastosis can occur with the ABO incompatibility. A mother who has an O blood type and who gives birth to a infant with an A or B blood type constitutes the most commonly seen ABO incompatibility. The treatment and nursing care are the same as for if she, like it was erythroblastosis fetalis. Okay. And here again, it has in here figure 14.3. It talks about the maternal sensitization producing erythroblastosis in the newborn. Okay. And here it is. It is in your book, the nursing tip, when RhoGAM is supposed to be administered. So you want to make sure again to highlight that so you can know when RhoGAM is to be administered. And also the nursing and treatment for erythroblastosis fetalis is prompt identification, the laboratory tests, drug therapy, phototherapy, and also exchange transfusion if needed. Okay. And it gives you some nursing care plans in regards to infants receiving the phototherapy. Okay, so next we have intracranial hemorrhage. Okay, and with the intracranial hemorrhage, just briefly, the most common type of birth injury. This may result in a trauma or anoxia. It occurs more often in preterm infants. May also occur during precipitate delivery or prolonged labor. And the signs and symptoms vary depending on severity. Okay. Transient tachypnea in a newborn usually occurs after a cesarean section birth or rapid vaginal delivery of a term infant. It's going to be characterized by the tachypnea, and that also may include chest retractions, grunting, and also mild cyanosis. The condition is often referred to as the wet lung or respiratory distress syndrome type 2. And the distinctive feature of this condition is that it typically resolves suddenly after 3 days. And the transient tachypnea of the newborn is thought to be caused by no absorption of the fluid in the lungs after birth. And treatment is going to be supportive, providing warmth, energy, conversation, and also supplemental oxygen to the newborn. Meconium aspiration, um, you know, when it happens in utero, we spoke about that earlier. So basically, the fetus expels meconium into the amniotic fluid, um, and you have the cord compression or other conditions and interrupts the fetal circulation. And if asphyxia or acidosis does occur, the fetus may have gasping movements that can cause meconium-stained amniotic fluid to be drawn into the lungs. So basically, if it happens at delivery, it can occur if newborns inhale before nose and mouth have actually been suctioned. Neonatal abstinence syndrome, um, caused by fetal exposure to in utero. Illicit drugs can cross the placental barrier, and the newborn is susceptible to that. And they can go through the drug withdrawals after birth. So the infant may also have long-term developmental and neurological defects. Infants of a diabetic mother. Again, it's more, and we went over this before in the other chapters, but just remember, large amounts of glucose are transferred to the fetus. It's going to cause the fetus to become hyperglycemic, and the fetal pancreas produces large amounts of fetal insulin, and this can lead to hyperinsulinism, and along with excess production of protein and also fatty acids often results in the LGA newborn weighing 9 pounds or more. And also remember that the babies can be very large, and which is we call it a macrosonia baby, a large baby. And the infant is prone to injuries at birth because of his or her size. And your book does give a wonderful picture of a baby that's macrosonia. That was on another chapter that you also saw there. Okay, thank you.